The United States, despite being home to some of the most advanced hospitals, innovative pharmaceutical companies, and high-tech medical devices, continues to lag behind many of its peer nations in one of the most basic measures of national health, life expectancy. This paradox of spending more on healthcare per capita than any other country while achieving poorer outcomes has become one of the most pressing public health puzzles of the 21st century. While it might seem that medical technology alone should boost longevity, the reality is more complex, with lifestyle, chronic disease burden, inequality, and even cultural attitudes toward health playing significant roles. One of the primary contributors to the U.S. life expectancy shortfall is the rising prevalence of chronic, preventable conditions such as obesity, diabetes, and cardiovascular disease. These diseases are closely linked to lifestyle patterns, particularly poor diet, sedentary behavior, and lack of access to consistent preventive care. Compared to many European or East Asian nations, Americans consume more ultra-processed foods, sugar-sweetened beverages, and large portion sizes, while engaging in less walking and physical movement as part of daily life. As a result, chronic illnesses take root earlier and are more difficult to reverse, even with access to medication. Beyond personal habits, structural and social factors play a significant role. The U.S. has a deeply fragmented healthcare system that makes consistent, affordable access to care difficult for many. Preventive services, early diagnosis, and long-term management of disease can be challenging for those without insurance or those who face high out-of-pocket costs. This often leads to delayed treatment, unmanaged conditions, and greater complications down the line. By contrast, nations with universal healthcare systems, such as Japan, the Netherlands, or Sweden, tend to emphasize early intervention and population-wide health maintenance, leading to fewer advanced disease cases and better long-term outcomes. Socioeconomic inequality is another major driver. Life expectancy in the U.S. varies widely based on income, education, and geography. People in lower-income communities are more likely to live in areas with poor access to healthy food, limited recreational spaces, environmental pollution, and higher rates of stress and violence. Chronic stress itself has biological consequences, increasing inflammation, accelerating aging, and raising the risk of mental health disorders, all of which shorten lifespan. The U.S. also faces high rates of drug overdose, suicide, and gun-related deaths, which disproportionately affect younger adults and contribute to what researchers have called deaths of despair. Mental health, too, is an underappreciated factor in longevity. Rates of anxiety, depression, and social isolation have risen in the U.S., particularly among young people and the elderly. While physical health infrastructure exists, mental health services often remain underfunded and stigmatized, leading to untreated conditions that erode both quality and length of life. In contrast, countries that integrate mental wellness more deeply into public health policy tend to see not only better mental health outcomes, but also longer average lifespans. Another subtle but influential factor is cultural. In many peer nations, there is a more collective sense of health responsibility. Public policies emphasize healthy food in schools, urban planning that encourages walking and biking, and social safety nets that reduce stress-related disease. In the U.S., health is often seen as a matter of individual responsibility, which can reinforce blame rather than promote supportive environments. This cultural lens may discourage population-level investments in infrastructure or policy reforms that support well-being across the board. Despite these challenges, there are reasons for optimism. Life expectancy gaps are not fixed, they are responsive to change. Cities and states that have implemented policies to improve walkability, increase access to healthy food, support early childhood education, and expand preventive care often outperform national averages. The growing awareness of the social determinants of health, such as housing, income, and education, is also beginning to reshape how public health is approached in the U.S. Furthermore, the rapid advancements in personalized medicine, longevity science, and digital health technologies offer enormous potential. If these innovations are paired with reforms in access, equity, and education, the U.S. could begin to close its life expectancy gap. But doing so will require a shift in priorities, from treating disease after it appears to building healthier communities before illness takes root. In essence, the United States does not lag in life expectancy because it lacks scientific knowledge or medical capability. It lags because of deeper societal imbalances, inequities in access, gaps in preventive care, and a cultural framework that sometimes separates health from the broader context of community and well-being. The good news is that these are not insurmountable barriers. With political will, cultural change, and a broader view of what health truly means, the US has the tools not only to catch up, but to lead.